Welcome back to the last unit of the last module on patient safety and clinical risk management, the foundational course. We learned about the stages of medication use and the various ways in which errors can creep in. Now let's look at the patient characteristics that make them most at risk for medication error. The most obvious and common has to be complicated medication regimes. Patients who are on multiple medications are most likely to experience some form of error. Comorbidities or pregnancy. Patients who may be unable to communicate well, maybe from a disability or following events like a stroke or a traumatic brain injury, or it may be an elderly patient with dementia. Having more than one doctor in charge of the patient, as may happen in units where there are many doctors who may round the patient alternate days. Or if a patient has multiple comorbidities, he or she may have a variety of specialists who are caring for them. Sometimes, especially in Indian setups, patients often don't take an active role in their own medication use. They may depend on their children or their caregivers, which adds to the likelihood of errors. And of course, whenever doses need to be adjusted and calculated, the potential for errors is high. Staff are most likely to contribute to errors when they are hurrying, when they are overworked, inexperienced, or their workflow is interrupted. When the nurse is doing her job, somebody comes and asks her a question and interrupts her work. She is likely to get distracted and errors are likely to occur at that point. We saw in previous modules how repetitive tasks can reduce one's attention, leading to errors. Poor habits such as failing to habitually check and verify, poor communication between the team members, and a reluctance to use memory aids. Maybe it may be a personal reluctance or even an organizational phenomenon. The workplace itself can contribute to medication errors by poor designs and lack of standard procedures, absence of organizational safety culture, failure to use the systems approach, heavy reliance on person approach makes learning from errors very difficult. And like I already said, absence of memory aids like charts, posters, digital aids, etc., and overburdened staff. When the workforce doesn't match up to the workload, fatigue becomes a very common reason for errors. We saw how marketing drugs under similar sounding names and even generic compounds with similar sounding names creates a lot of confusion. These are the LASA drugs, the look-alike, sound-alike drugs. We discussed Lamitor and Lamivir. Ambiguous labeling, when labels of two drugs look very similar. Look at this example. Okay, this is an example of a look-alike, sound-alike drug, and the reference for this image is given to you on the screen. These are vials of rocuronium, heparin, and midazolam, and they all look similar. How likely is it that an error will occur when all these are stored together, as may occur in an operation theatre? We can make medication use safer in many ways, and it starts with knowing how and when medication errors occur. Use generic names of drugs while writing prescriptions or printing out prescriptions. For example, write amoxicillin and potassium clavulinate, metoprolol, carbamazepine, etc. instead of brand or trade names. Ensure your prescriptions are tailor-made to the individual patient. Take into consideration history of allergies, medical comorbidities, especially hepatic or renal impairment, what other medications they may be already taking, whether the patient is pregnant or breastfeeding, age and weight of the patient. These tie into the next way you can ensure medication safety, that is, habitually collecting complete medical and medication histories. Details of what medications the patient is already on, such as the drug name, dose, frequency, route, duration. All of this data must be collected for each and every drug that the patient is on. Ask about any medications that may have been stopped and understand the reasons for stopping. Were there intolerable side effects or did the medication not work? Find out if there is any over-the-counter medication, nutraceuticals or supplements that the patient is consuming. Does the data you have in the documents corroborate with what the patient is telling you about their medications? If you notice any medications you are not familiar with, Look them up, keep the possibility of drug interactions, and ensure that you have taken all of that into consideration before prescribing. History of allergies, like I mentioned earlier, must be recorded and correctly documented so that even in the future, those medications are not inadvertently prescribed and administered to the patient. Make a list of narrow therapeutic window drugs relevant to your practice, potent drugs, drugs with too many interactions, for example, carbamazepine or certain antifungals, drugs which have complex dosing and monitoring schedules. Other examples of such high-risk medications include oral anticoagulants, insulin, chemotherapeutic agents, muscle relaxants, intravenous calcium, potassium, and others. It is not reasonable to expect us to know the vast array of medications that are used by all specialties. However, we must be familiar with all the necessary information regarding the medications we use routinely. So, I am a psychiatrist and it is expected that I should be very familiar with the psychotropic drugs that I routinely use, including knowing the indications for use of each drug, its contraindications, side effects, any special precautions with the drug, and dosing information. We have already discussed this n number of times. Use memory aids. We don't need to know everything by heart. So place information charts, infographics, flow charts around your workplace. Use pocket drug guides and handbooks published by reliable agencies. Stick to protocols and procedures. And if you can't remember something or you feel doubtful, just go look it up. The 5 R's of prescribing and administering the right drug in the right dose by the right route at the right time to the right patient. Clear communication has been emphasized enough and repeatedly. Remember to close the communication loops using check back or read back method that we have discussed previously, and write legibly. Develop a habit of checking and verifying at every stage of medication use, even if you are using electronically generated prescriptions. Do not administer medications which seem doubtful to you. If you cannot read the label or the expiry dates properly, or if there are loose medications, just discard them. Always label the injections that you drop, and this is especially true in the operation theatres and ICUs. Encourage your patients to become active in the process of medication use, even if they have limited knowledge or literacy. Make them understand the importance of maintaining their health records and keeping documents, showing them to their doctors whenever they visit for a checkup. Educate them regarding common side effects to watch out for, and teach them how to monitor themselves. For example, keeping track of their blood sugars using a glucometer in patients with diabetes. As always, learn from errors. Document and report medication safety incidents so that they can be scrutinized to prevent a recurrence. And for doing this successfully, you must contribute to the safety culture at your workplace. To summarize, medications are indispensable to the healthcare system. Patient lives depend on them. Yet medication errors are the most common in healthcare. They are preventable, and knowing your responsibilities as a healthcare professional and creating favorable habits can significantly reduce the likelihood of errors on our end. With that, we come to the end of this last module of this course. I hope the learning experience was a rich one and that you have found some ways in which you can become a patient safety advocate yourself. Thank you and namaste.